Pecoraro.
I'm Mel Akerman.
And I'm Anne Woolfield, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things O&G. It's time for another episode of Evidence with Anne, where we will take the RANZCOG landmark trials and convert them from tedious learning to palatable sound bites for your listening pleasure. Today's epic task is to cover the landmark trials on antenatal corticosteroids. We'll cover the ACTORDS, ASTEC, and the ALPS trial.
What a topic. Antenatal corticosteroids have arguably been the greatest contributor to the health of preterm babies in the last 50 years, and I believe they have quite an interesting history. Mel, would you like to do the honours?
Always. Most people don't know this, but the idea of using steroids for fetal lung maturation actually originated in New Zealand, and like most great inventions, by mistake. Our star of the show here is Professor Graham Liggins, who was an obstetrician working at the National Women's Hospital in Auckland in the 1960s. Dr. Liggins had this idea that the baby, rather than the mother, provided the key trigger for the onset of labour, and that fetal trigger was fetal glucocorticoids. He was working on sheep at the time and managed to show that if you stop fetal glucocorticoid production by removing the pituitary or adrenal glands, then you actually prevent the onset of labour. But then if you give the fetal sheep glucocorticoids, you can precipitate labour.
Far out, that is so random, Mel, but it's good. And how does it relate to how we use steroids today?
Well, most lambs that are born preterm die, right? Well, while Professor Liggins was triggering labour in sheep at all gestations, he noticed that lambs born preterm after steroid administration were born alive and breathing. The steroids seemed to accelerate the appearance of surfactant, allowing the lungs to inflate. He published this finding in 1969 and reasoned that if steroids have this effect on lambs, then surely they would also have that effect on babies. At the time, most preterm babies were dying of lung disease due to surfactant deficiency, so there was certainly a lot of interest from the neonatal community. Together with the local neonatologist, Associate Professor Ross Howie, Liggins and Howie began a randomized placebo-controlled trial of antenatal corticosteroids.
Now, here's a trial that was truly a landmark study. The team published their initial findings in 1972 after showing that antenatal corticosteroids reduced neonatal mortality from 15 to 3% and respiratory distress syndrome from 26 to 9%.
Landmark indeed. And get this, when Liggins and Howie first went to publish the interim findings of their trial, they actually got rejected by the Lancet because it lacked general interest. Bet they're kicking themselves now. But let this be a lesson to all our budding researchers out there. If at first you don't succeed, try a different journal.
Absolutely. The findings of Liggins and Howie were published in 1982, and following this, many other trials were performed to try and confirm the findings. All of them showed similar results, which were synthesized in a systematic review in 1982 by Patricia Crowley. Now, here's another fun fact. You know the Cochrane Library logo? Well, if you look closely, the logo is actually a forest plot of 7 RCTs from that initial Cochrane review. Now, one of the other findings from the original Liggins and Howie study was babies that get the greatest effect from antenatal corticosteroids if they are born between 1 to 7 days after the first dose, which brings us to our first clinical question. Should we be giving a repeat dose of steroids to women who don't go into preterm labour within 7 days? Enter the ACTORDS trial. And take it away.
Finally, let's get into these trials. The ACTORDS trial is better known as neonatal respiratory distress syndrome after repeat exposure to antenatal corticosteroids, the ACTORDS trial, an RCT. It was published in The Lancet in 2006 by Crowther et al. You might remember Professor Caroline Crowther from our last Evidence with Anne episode on magnesium sulfate. She was the author of the latest Magenta trial.
On the use of magnesium sulfate for fetal neuroprotection between 30 and 34 weeks, that one? Is there anything this woman can't do? Professor Crowther, tell us your secrets. Please tell us you listen weekly.
So the aim of the ACTORDS trial was to answer the question, do repeat courses of prenatal corticosteroids given to women at risk of preterm birth reduce neonatal morbidity without harm? This was a double-blind, placebo-controlled, multi-centre RCT conducted in 23 hospitals in Australia and New Zealand between 1998 and 2004.
Yes, Australia and New Zealand.
The trial included 982 patients who remained at risk of preterm birth, less than 32 weeks gestation, 7 days or more after their steroids. Participants were randomized to either repeat betamethasone or placebo every week if they remained undelivered and less than 32 weeks. The primary outcome was occurrence and severity of neonatal respiratory distress syndrome, use and duration of oxygen, ventilation, weight, length and head circumference, and hospital discharge. Secondary outcomes included chorioamnionitis requiring intrapartum antibiotics, maternal postpartum fever, side effects, and measures of neonatal morbidity. The trial was analysed by an intention to treat analysis that was adjusted for gestational age at entry, APH, and PPROM.
Okay, I need to do a summary mainly for myself, but also for our listeners. The ACTORDS trial is neonatal respiratory distress syndrome after repeat exposure to antenatal corticosteroids, the ACTORDS trial, and RCT. The aim was to determine the role of repeat doses of corticosteroids for women who remained at risk of preterm birth 7 days after their initial course of steroids. It was a double-blind, placebo-controlled, multi-centre RCT in 23 centres in Australia and New Zealand between 1998 and 2004. 981 participants at risk of preterm birth after the first dose and under 32 weeks were randomised to either weekly betamethasone or placebo, and the primary outcome was RDS. All right, what were the results? Drum roll, please.
So the ACTORDS trial showed that repeat doses of steroids resulted in a reduction in the rates of RDS and severe lung disease, a reduction in oxygen requirements, and a shorter period of time ventilated. The reduction in RDS is pretty impressive, dropping from 41 to 33%, a relative risk of 0.81. The reduction in severe lung disease was almost halved by dropping from 20 to 12%, with a relative risk of 0.6. The number needed to treat to benefit was only 14 to prevent one baby from having RDS or severe lung disease, this is actually pretty good.
Were there any adverse effects?
Not really. Importantly, there was no difference in birth weight, neonatal infection, chorioamnionitis, or postpartum fever. There was also no difference in NICU admission, length of stay, APGAR, intraventricular hemorrhage, severe IVH, periventricular leukomalacia, neck, or retinopathy of prematurity.
Okay, what about long-term harms? I know people are always concerned about giving too many doses of steroids because of the possible risks on fetal growth or neurodevelopment. Was there any follow-up to the ACTORDS trial?
Yes, there actually was. So 96.5% of the children who were alive at 2 years were followed up. I think that's pretty impressive to get that kind of follow-up 2 years later. It was a questionnaire-based study that essentially showed that there was no significant differences between the groups in body size, blood pressure, use of health services, respiratory morbidity, or child behaviour scores. There was no difference in major neurosensory disability. The only thing that was different between the two groups is that those with repeat doses of steroids were more likely to warrant assessment for attention problems. But no, this didn't actually mean that they had more attention problems, just that they were being assessed for it. They also had slightly higher rates of poor school performance as reported by the parents and teachers.
So what were the implications of this trial?
So the ACTORDS study is one of the largest and earliest studies that looked at the use of repeat doses of antenatal corticosteroids for women who remained at risk of preterm birth below 32 weeks. The trial provided good support for the use of repeat corticosteroids for women who remain at risk of very preterm birth under 32 weeks and is one of the driving trials behind our current guidelines, which recommend the 2-dose options of either a complete repeat course of 2 doses of steroids or single weekly injections with a single dose. Obviously, there have been several more trials since then, but this was one of the landmark trials that you should really know about.
Okay, Mel, using your own motto, repetition, repetition, repetition. The ACTORDS trial is neonatal respiratory distress syndrome after repeat exposure to antenatal corticosteroids, the ACTORDS trial, an RCT. It aimed to determine the role of repeat doses of corticosteroids for women who remained at risk of preterm birth 7 days after their initial course of steroids. It was a double-blind, placebo-controlled, multi-centre RCT in 23 centres in Australia and New Zealand in 1998 to 2004. There were 981 participants at risk of preterm birth after the first dose and under 32 weeks, and they were randomised to either weekly betamethasone or placebo. The primary outcome was RDS, and the study showed that repeat doses of antenatal corticosteroids reduced the risk of RDS from 41 to 33%, reduced severe lung disease from 20% to 12%, reduced oxygen requirements, and reduced the duration of ventilation. Importantly, there was no change in biometric parameters or infection.
Thanks, Carla. All right, let's get into our next trial, the ASTEC trial. The ASTEC trial is another of our RANZCOG landmark trials and aims to address the question of whether or not we should give steroids for term elective caesarean. Mel, what can you tell me about this trial?
Okay, so the ASTEC trial is also known as Antenatal Betamethasone and Incidence of Neonatal Respiratory Distress After Elective Caesarean Section, a pragmatic randomized trial. ASTEC itself stands for Antenatal Steroids for Term Elective Caesar. Why they can't just call the trial the same name as its abbreviation, I just don't know. The ASTEC trial was published in the BMA by Stutchfield in 2005. And the aim of the trial was to test whether steroids reduced respiratory distress in babies born by elective caesarean section at term. It was a multi-centre, pragmatic randomised trial set in 10 hospitals in the UK from 1995 to 2002.
What the heck is a pragmatic randomised trial?
And
so, to be honest, until reading this study, I did not know what a pragmatic randomised trial was either. The point of a pragmatic RCT is to answer a question of treatment in a real-world scenario. One main difference is the population. In a pragmatic RCT, the idea is to enrol participants reflective of the real-world population rather than the perfect patient, as might be defined by a standard RCT. There was also no placebo.
Right. So this pragmatic RCT had 998 participants with a planned Caesar from 37 weeks and above. Women were randomized to either 2 doses of 12 milligrams betamethasone in the 48 hours prior to delivery or no treatment, and the primary outcome was admission to special care nursery with respiratory distress.
The secondary outcomes included the severity of respiratory distress and the level of care that was required in response. The diagnosis of respiratory distress was made by tachypnea with grunting, recession, or nasal flaring. They actually did a chest x-ray to work out and made the definition of either TTN or RDS. Patients were excluded if they had severe maternal hypertension, previous peptic ulcer, severe rhesus sensitization, or an intrauterine infection. They were excluded prior to analysis if there were twins delivered less than 37 weeks or there was no data after randomization and it was intention to treat.
Okay, so quick recap. ACTORDS, repeat steroids. ASTEC, term Caesar. So the ASTEC trial is called Antenatal Betamethasone and Incidence of Neonatal Respiratory Distress After Elective Section, pragmatic randomized trial. It was published by Stutchfield in the BMJ in 2005. It aimed to assess the role of steroids for women giving birth by Caesar after 37 weeks. It was a multi-centre pragmatic RCT that randomised almost 1,000 women to either 2 doses of betamethasone or nothing 48 hours prior to a Caesar. And the primary outcome was admission to the special care nursery with respiratory distress, and there was a secondary outcome of the severity of respiratory distress. Have we gotten to the results yet? What are they?
So the ASTEC trial showed that antenatal betamethasone given to women 48 hours prior to term elective caesarean section halved the rate of special care nursery admission from 0.050 to 0.024, halved the rate of TTN from 4% to 2.1%, and reduced the incidence of RDS from 1.1% to 0.2%. And if we go by gestation and look at no steroids versus steroids, the rate of admission to the nursery for 37 weeks was 11.4% versus 5.2% with steroids. For 38 weeks, 6.2% versus 2.8% with steroids. And for 39 weeks, 1.5% versus 0.6% with steroids. So basically, you could give steroids to reduce the rate of SEN admission. But if you just wait and do the cesarean at 39 weeks without giving steroids, that has a pretty similar benefit. If you ever wondered why we book our caesarean sections at 39 weeks, then this is one of the main reasons, to reduce the risk of respiratory distress. Now, what were some of the limitations?
I guess some of the downsides of a pragmatic RCT is that there was no blinding of participants and professionals, there was no placebo, and this randomization was not stratified. There were actually very few neonates who ended up with respiratory distress syndrome. The majority of the reduction in nursery admission was secondary to TTN. There was also quite a wide confidence interval. I'm also not quite sure why the twin pregnancies were included in the randomization, but then they're excluded prior to analysis. A good thing is that it has identified rates of admission to the nursery for different gestations at term.
Okay, summary time. The ASTEC trial is called Antenatal Betamethasone and Incidence of Neonatal Respiratory Distress After Elective Caesarean Section, a pragmatic randomized trial. It was published by Stuchfield in the BMJ in 2005. It aimed to assess the role of steroids for women giving birth by a caesarean section after 37 weeks. It was a multi-center pragmatic RCT that randomized almost 1,000 women to either 2 doses of betamethasone or nothing 48 hours prior to a Caesar. The primary outcome was admission to special care nursery with respiratory distress, and secondary outcome was the severity of respiratory distress. The study showed that giving steroids to women about to undergo elective Caesar halved the rate of admission to special care from 0.05 to 0.024. Halved the rate of TTN from 4% to 2.1%, and reduced the incidence of RDS from 1.1% to 0.2%. But also, if you just wait until 39 weeks to do a Caesar, then the rates are pretty low anyway.
So there have obviously been many trials since this one, and the argument of whether to give steroids prior to Caesar is still there. A full discussion on this is definitely beyond the scope of this episode today, but feel free to dive right down that rabbit hole. Also, keep an eye out for the next likely landmark trial in this area, the C-STAR steroid trial. This trial is currently recruiting in Australia and New Zealand and aims to look at whether giving mothers corticosteroid injections before having a planned caesarean at 35 to 39 plus 6 weeks of pregnancy will safely reduce the risk of short-term breathing problems for babies. Okay, let's move on to the next trial, the ALPS trial. Antenatal betamethasone for women at risk of late preterm delivery. Should we be giving steroids at late preterm gestation?
Okay, so the ALPS trial was published in the New England Journal of Medicine in 2016 by Gyamfi Bannerman. The aim of this trial was to see if betamethasone administered to women at risk of late preterm delivery, so 34 to 36 weeks, would decrease the risk of neonatal morbidity. It was a multi-center, double-blind, randomized, placebo-controlled trial conducted in 17 hospitals in the United States between 2010 and 2015. The participants were women with a singleton pregnancy at high risk of delivery during the late preterm period, 34 to 36 plus 5 weeks. There were about 1,400 women in both the intervention and placebo group.
The intervention was 2 doses of IM 12 milligrams of betamethasone, 24 hours apart. The randomization was stratified by clinical site and gestational age, so 34 to 35 weeks versus 36 weeks. Mel, what were the inclusion criteria for this one?
So the inclusion criteria included those with a high probability of delivering between 34 and 37 weeks. The definition of a high probability of delivering was pretty strict and included preterm labour with intact membranes and either at least 3 centimetres dilatation or 75% cervical effacement, or PPROM with contractions greater than 6 an hour or more than 3 centimetres dilatation, or planned preterm delivery for any indication through induction or Caesar within 7 days.
The exclusion criteria included those who had previously received steroids throughout the pregnancy, those who were expected to deliver within 12 hours, chorioamnionitis, dilated over 8 centimetres, evidence of fetal distress requiring immediate delivery, a lack of dating scan less than 32 weeks if last known menstrual period, or dating ultrasound less than 24 weeks if there was an unknown last known menstrual period. Far out, that's a mouthful. Oh.
The primary outcome was a composite of treatment in the first 72 hours, stillbirth, neonatal death within 72 hours of delivery. The treatment part of this included CPAP or high-flow nasal cannula for at least 2 hours, supplemental oxygen with a fraction of inspired oxygen of at least 0.3 for at least 4 hours. The secondary outcomes included severe respiratory complications, but please refer to the whole article because there is a whole paragraph listing the secondary outcomes. The maternal secondary outcomes included chorio, endometritis, delivery before completion of the course, length of hospitalization. There were subgroup analyses for gestational age, indication for trial entry, planned caesarean versus planned vaginal birth, infant sex, race, and ethnic group.
Okay, my turn for a recap. The ALPS trial is known as Antenatal Betamethasone for Women at Risk of Late Preterm Delivery, published by Gyamfi Bannerman in the New England Journal of Medicine in 2016. It aimed to assess the effect of antenatal corticosteroids in the late preterm period. It was a multi-center, double-blind, randomized, placebo-controlled trial conducted in 17 hospitals in the USA between 2010 and 2015. 2,800 women between 34 weeks and 36 weeks plus 5 days were randomized to 2 doses of betamethasone or placebo if they were at high risk of preterm birth. And remember, that was defined as preterm labor with intact membranes over 3 centimeters or dilatation or 75% effacement, PPROM with contractions or dilated more than 3 centimeters, and planned preterm birth for any indication. The primary outcome was a composite of neonatal treatment in the first 72 hours, including use of CPAP, oxygen, ECMO, and stillbirth. And the secondary outcome were many, including respiratory complications and, importantly, hypoglycemia. Carla, what were the results?
So, the ALPS trial showed that the primary outcome occurred less often in the betamethasone group, at 11.6% versus 14.4% in the placebo group. A reminder that the primary outcome was a composite of treatment in the first 72 hours, stillbirth, neonatal death within 72 hours of delivery. Severe respiratory complications occurred less frequently in the betamethasone group, 7.9% versus 12.1%, with a number needed to treat at 25. The rates of TTN, bronchopulmonary dysplasia, both of these were lower in the treatment group as well.
There was no difference in the rates of respiratory distress syndrome, apnea, pneumonia. There was a reduction in the use of surfactant and resuscitation in the treatment group. There was no significant differences between the two groups for choreo, neonatal sepsis, gestational age at delivery, NEC, IVH, hyperbilirubinemia, or hypothermia. In contrast, neonatal hypoglycemia was more common in the betamethasone group, 24% versus 15%, with a relative risk of 1.6, with a narrow confidence interval and a p-value of less than 0.01. No stillbirths or neonatal deaths occurred within 72 hours. There was no difference in caesarean, time to delivery, and maternal length of stay.
So, for our final recap, the ALPS trial is known as Antenatal Betamethasone for Women at Risk for Late Preterm Delivery, published by Gyamfi Bannerman in the New England Journal of Medicine in 2016. It aimed to assess the effect of corticosteroids in the late preterm period. It was a multi-center, double-blind, randomized, placebo-controlled trial conducted in 17 hospitals in the United States between 2010 and 2015. 2,800 women between 34 and 36 and 5 weeks were randomized to 2 doses of betamethasone or placebo if they were at high risk of preterm birth, which was defined as preterm labor greater than 3 centimeters or 75% effacement with membranes intact, PPROM with contractions or greater than 3 centimeters dilatation, and a planned preterm birth for any indication. The primary outcome was a composite of neonatal treatment in the first 72 hours, including the use of CPAP, oxygen, ECMO, and stillbirth. The secondary outcomes were a lot, including respiratory complications and hypoglycemia. And the study showed that corticosteroids for late preterm birth reduced the rates of TTN and bronchopulmonary dysplasia, 9.9% versus 6.7%, did not reduce the rates of RDS, but did significantly increase the rate of neonatal hypoglycemia, 24% versus 15%.
Now, the ALPS trial has been a little controversial, with a recommendation in our guidelines now to consider the use of late preterm steroids, with particular adherence to the inclusion criteria of the ALPS trial. However, there have been a few concerns raised. Firstly, the ALPS study showed a reduction in TTN with similar rates of RDS and mechanical ventilation. As we know, transient tachypnea of the newborn tends to be a transient self-limiting condition, and most babies with TTN will improve. This is balanced by the significant increased risk of neonatal hypoglycemia, as well as the possibility of long-term adverse effects of corticosteroids. Secondly, about 80% of women in the ALPS trial actually went on to have preterm labor. This is significantly more than clinical practice. As you all know, our ability to predict preterm birth with late prematurity is terrible. Our fetal fibronectin can't be used above 35 weeks because of false positive rates, and the cervical length tends to naturally shorten closer to labor, and so our concern is that many women who we expect to go into preterm labor may actually deliver at term. And if these women get steroids, then there is absolutely no benefit for them or their babies, but there is an increased risk of neonatal hypoglycemia and the potential for long-term harms. For this reason, you should be cautious in your decision to administer late preterm steroids.
All right, and those are the RANZCOG landmark trials. They try to answer some of the questions we all have about antenatal corticosteroids, and conveniently, they all start with A. So, ACTORDS looks at respiratory distress rates for repeat doses of steroids. ASTEC looks at the use of steroids for term elective Caesars, and ALPS looks at antenatal corticosteroids for late preterm labour. To summarise the benefits of steroids in pregnancy, let's chat about the 2020 Cochrane review.
If you're bored, stop listening now. But if you just want a little bit more information on antenatal corticosteroids, keep on listening. So the Cochrane review, titled Antenatal Corticosteroids for Accelerating Fetal Lung Maturation for Women at Risk of Preterm Birth, it was published by McGoldrick in 2020. It's an update on the previous Cochrane reviews, and it's a heavy 220 pages of reading. Now, rather than going through all the details, we just want to summarize some key points for you in case this comes up in exams.
So, the Cochrane review showed that antenatal corticosteroids have been shown to reduce the risk of perinatal death, neonatal death, and respiratory distress syndrome.
Antenatal corticosteroids probably reduce the risk of interventricular hemorrhage, probably have little to no effect on birth weight, and probably lead to a reduction in developmental delay in childhood.
And finally, antenatal corticosteroids probably result in little to no difference in maternal death, chorioamnionitis, and endometritis.
Great. All right. There are heaps of benefits. What are the downsides?
Well, we've already discussed in the ALPS trial that there was a risk of hypoglycemia for the baby after it's born. Next, we'll have a quick chat about an observational study. I certainly noticed a hesitancy in many of my colleagues in prescribing steroids after this article was published. It's titled Associations Between Maternal Antenatal Corticosteroid Treatment and Mental and Behavioural Disorders in Children, and was published in the JAMA in 2020.
This was a population retrospective cohort study conducted in Finland. All the data available for the study was collected from medical records or registers. There was data for over 670,000 children born between 2006 and 2017, of which nearly 15,000 received antenatal steroids. Of those who had steroids, 46% went on to deliver at term. This study found that steroids compared with no steroids was associated with a higher risk of any mental and behavioural disorder, and that this was present for the entire cohort, those who ended up being born at term, and for sibling pairs.
Okay, so we've discussed all these benefits, but now you're telling me that there is a higher chance of mental and behavioural disorders, so we shouldn't give steroids?
So first, it's important to consider the clinical picture. So based on this cohort study, 46% of those who were treated with steroids went on to deliver at term. Hence, there was no benefit for these babies to have them in the first place. As we discussed in our preterm birth series, there are many things we can do to try and predict those who are going to go into preterm labour. It's really important to use those so that we can treat patients appropriately. And as was highlighted in this study, the outcomes were worse in those that ended up being delivered at term who were giving steroids preterm. There are some obvious limitations to this study. First, it's an observational study. If you remember back to those evidence-based medicine lectures at university, this limits our causal inference. So we can't really say that it causes, but we can just say that there's an association. Despite the most amazing statistical analyses, there will always going to be some residual confounding, which will be present in this study. Because the data for this study was drawn from medical registers, the exact timing and dosing of steroids was unknown. And lastly, the finished population is very homogeneous, which limits its generalizability.
Alrighty, and that summarises all of our studies. It's really important to carefully consider who we give steroids to. And we know it was a bit of a marathon discussing all of these studies, so thanks for sticking along with us. And thank you, Anne, for writing this extraordinary episode. And thanks for listening to The Uterine Sound. Check us out on Instagram at The Uterine Sound or email us at theuterinesound@gmail.com. Check out our website at theuterinesound.com. Let us know if you have any questions, queries, or want to fact check us.